bloodstream, while the exocrine, it's mostly for the digestive enzymes, and it's going to be through ducts. It's lying transversely across the posterior abdominal wall, which means it's retroperitoneal. But only the tail, we are having a 5 parts for the pancreas. The tail of the pancreas is intraperitoneal structure. The extension from the concavity of the duodenum, as you can see here on this picture, we are having the duodenum. It's going to extend from the concavity of the duodenum to the spleen. It lies in the epigastric and the left hypochondral region. The neck of the level is going to be on the L1 vertebra. The parts, as we already said, they are 4 or 5, we can say, because we are having the unsafe process. Firstly, we're going to start with the blue structure, which is going to be the head, the expanded and has the unsafe process, as we already said. Then we are having the neck, it's the constriction part of the head. Then we are having the body, which is the main bulk of the glands. Mainly all the glands are there. Then we are having the tail, which is the tapered end of the gland. And as we said, all those parts are retroperitoneal, except for the tail, it's intraperitoneal, which means it lies inside the peritoneal cavity. And here we have a real image for the pancreas. We are having the unsated process. Here we are having the head, then the neck, the body, and ending by the tapered end, which is the tail. Regarding the function, it has a dual function, as we already said, because it has an exocrine function as well as an endocrine function. The exocrine function produces the enzyme for digestion, while the endocrine function produces hormone like glucagon and insulin. Those are the most two important. So as we said, about 1.5 liter of alkaline digestive enzymes are secreted daily as the exocrine, while the endocrine cells are found in clusters. We call those clusters islet of Langerhans. We will know more about them. Regarding the pancreatic ducts, because as we already said, we are having endocrine directly to the bloodstream, while for the exocrine, we should have a pancreatic duct. So we are having 2 ducts. One's called the main pancreatic duct, and from the name, it's the main one. Majority of the hormones are going through this duct, as well as we are having the accessory pancreatic ducts. Starting with the main pancreatic duct, start at the tail of the and passes to the right. It descends to join with the bile duct. So as we can see here, we are having the common bile duct coming from the gallbladder and the hepatic. It's gonna extend. Here we are having the common bile duct, and here we are having the main pancreatic duct. Both of them are gonna descend together and join and forming an open here. This open is gonna be in the what? In the duodenum. We will call it the major duodenal papilla. And there is a sphincter there to regulate the opening and the closing. What we will call this sphincter? It's sphincter of Oddi. Okay, this is regarding the main pancreatic duct. So the open is going to be into the major duodenal papilla. Which sphincter is there? Sphincter of Oddi. Regarding the accessory pancreatic duct, start at the lower part of the head, as we can see this one here, and it ascend in front of the main duct. So it's not going to join anything. The main pancreatic duct will join with the bile duct, while for the accessory, it's only from the pancreas. Regarding the blood supply and the innervation of the pancreas, we want to end up by having 3 main arteries to supply the pancreas. What are those? We are going to start by the branches. We are having the SAMA, superior mesenteric artery, gastroduodenal artery, and the splenic artery. Each one of those is going to give us the direct branch for the pancreas. But we should always remember that we want to end up having 3 main arteries. Then we will remember that those 3 arteries are coming from 3 branches for sure. Starting with this one, which is the superior mesenteric artery, will give us what? The inferior pancreaticoduodenal artery. Inferior pancreaticoduodenal artery, and from the name, it's going to supply the inferior part. While the gastroduodenal artery will give us what? The superior pancreaticoduodenal artery. So now we are supplying it from the inferior part and from the superior part for the pancreas. Lastly, we know that we are having the splenic artery going directly to the spleen, which is the splenic artery is one of the branches from the celiac trunk. So while it's going to the spleen, it's going in a tortuous manner to supply what? To supply and give us the branches for the pancreatic artery, as well as, if we remember, the fundus of the stomach is going to be also apart from the splenic artery. So the splenic artery will supply the spleen, as well as it will give us a branch for the fundus of the stomach and some pancreatic arteries. Regarding the innervation, for sure we know that in our body the autonomic nervous system, including parasympathetic and the sympathetic. The parasympathetic innervation originates from the vagus nerve, while the sympathetic innervation from the greater and the lesser splenic nerves. طيب, the pancreatic tissue. We are going to start to go deep to know about the histological features of the pancreas. As we already say, two components, endocrine and exocrine. We should know that the exocrine consists of 80 to 90% of the pancreas, while the exocrine function, as we said, include the synthesis and the release of the digestive enzyme into the duodenum, as we already said, which is sphincter of Oddi. While the endocrine function involves the release of insulin glucagon into the bloodstream directly, so there is no ducts. We already explained about the main pancreatic duct and the accessory duct. Those two are for the exocrine function. For what? For the digestive enzymes. While when we are talking about insulin and glucagon, it's going to be directly into the bloodstream. Two important hormones responsible for what? For the regulating of our glucose, as we said, lipid and the protein metabolism. طيب, for the exocrine part, again, enzyme rich in what? In the alkaline fluid, into the duodenum. And it's very important to neutralize what's happening in our GIT system. Because mainly when we are talking about the stomach, it's high with acidity, so the pancreas will neutralize this by secrete a rich alkaline fluid. It's secreted from the what? Serous acini. While, as we said in the previous slide, the endocrine will gonna be what? Islet of Langerhans. This is going to be the shape of it, and it includes many cells. We are having the alpha cells, the beta, delta, and gamma. But we should focus mainly on alpha and beta. Alpha, it's going to secrete the glucagon, while beta, it's going to secrete the insulin and amylin. Delta and gamma, as we said, also they are there. Regarding the serous acini for the digestive enzyme, they are what? Berry-shaped group of exocrine cells secreting the digestive enzyme. They are basophilic rare nuclei at the base of the cell. Histologically, we can know the exocrine by looking at the shape under the microscope. It's going to appear as a nuclear at the base and xenophilic at the what? At the apex of the cells itself. The type of the pancreatic enzymes, the digestive pancreatic enzymes, we are having the lipase, amylase, protease. For the amylase, for starch digestion, secreted in the active form. We should mention a very important point that always everything is secreted in active form, while after it's go to the duodenum, it's going to be activated, while for the amylase, it's going to secrete it in the active form directly. So amylase for the starch digestion. What about lipase? Lipase for the lipid from the name. And for protease, it's going to be for what? For protein digestion. Then we are having trypsinogen, which is the inactive form. We should activate it and convert it into trypsin. So as we can see here, convert it to the active enzyme, which is what? Which is trypsin. Then this trypsin will gonna go and activate all the others pro-enzymes and cleaving of the what? Additional trypsinogen molecules into active trypsin. So we call it a positive feedback. We are having a trypsinogen converted into a trypsin. Then this trypsin will activate all the other pro-enzymes, as well as it's going to activate the trypsinogen into trypsin. How it's converted from trypsinogen into trypsin? And I even remember in 1.5 we have a question about this from Dr. Ahmed Sayed's lecture. Enterokinase or enteropeptidase? He's going to give us a scenario and asking us about the conversion from trypsinogen, which is in active form, to the active form. This is going to be via what? Enterokinase or enteropeptidase. Regarding the ductal cells and the acinar cells, as we already said, how we are going to regulate the exocrine secretions? It should be regulated by what? CCK, secretin, and the vagus nerve, the parasympathetic. The CCK mainly, it's going to stimulate the enzyme secretion by what? By the acinar cells. While the secretin also it's going to stimulate it by what? But for what? For the ductal cell. So as we can see here on the picture, here we are having the acinar cells, and here we are having, here are the ductal cells, and here are the acinar cells. Each one need to get activated. CCK will stimulate the acinar cells, while secretin is going to stimulate what? The ductal cells. While the parasympathetic via the vagus, it's gonna stimulate both the acinar and the ductal. Okay, to have a comparison between acinar and ductal, the acinar secrete all the pancreatic what? Enzymes, secrete a protein-rich digestive enzyme secreted in our plasma-like fluid. 25% of the total pancreatic secretion, while for the ductal it's 75%. Stimulated by what, as we already said, CCK and what? Acetylcholine via the what? Via the vagus and the parasympathetic. What about the ductal? It's gonna secrete what? The bicarbonate-rich fluid that alkaline and what hydrates the protein-rich secretion. Also, as we already said, 75% of the pancreatic secretion will be this. And it's stimulated by what? By the vagus via the parasympathetic, as well as secretin is mainly here, while CCK is mainly for the acinar cells. So again, as we already said, hormonal control, again as a quick recap, stimulation via what? CCK, gastrin, acetylcholine, secretin, and VIB. The inhibitors will be what? Somatostatin. We should always remember somatostatin is going to inhibit all of this. And somatostatin itself, it's going to inhibit the CCK and it's going to inhibit the secretin. And for the neuronal control, we already mentioned about it. Parasympathetic, it's going to be via the vagus, increase the rate of the secretion, while the sympathetic inhibit the secretion. Because as we always remember, the autonomic nervous system, fight and flight will be the sympathetic, while the parasympathetic will be for what? Rest and digest. So for the sympathetic, for sure, it's fight and flight. So we are going to inhibit the secretion, no time for digestion. Same goes for here. It shows the CCK, it shows the secretin, and we should know that the CCK, it's secreted via the what? From the duodenum, from the eye cells, and it's going to go and what? Activate and stimulate the pancreatic secretion. Same is going to be for secretin from S cells. And what's going to inhibit what's happening here? Somatostatin, as we said. طيب, moving now to pancreatitis. We should know that from the name, itis means that we are having an inflammation of the pancreas, which should differentiate it into acute pancreatitis and the chronic pancreatitis. The acute pancreatitis, it's auto-digested by the own enzymes. As we already mentioned, that everything in the pancreas is in inactive form. We should then convert it into active form when we are reaching the duodenum and the GIT tract. So those like trypsinogen get converted into trypsin, and all the other pro-enzymes get converted and get activated before reaching the GIT, which is mean they are still on the pancreas. What do we have here? We are having an auto-digestion, which means the pancreas, those enzymes are eating the pancreas itself. So we are having inflammation and hemorrhage, as we can see in all of those sites. What about the chronic pancreatitis on the other hand? It's caused by the inflammation. There are many other causes, and even having acute pancreatitis many times or untreated acute pancreatitis can be converted into a chronic pancreatitis. So there is an impairment in the endocrine as well as the exocrine function. And the next slide is going to also focus how we could differentiate by diagnosing and the clinical pictures between the acute and the chronic. طيب, again for the acute, as we said, acute pancreatitis is a sudden inflammation of the pancreas, which results in swallowing and pain, as well as poor digestion. And always we are having a swelling, pain, poor digestion, and regarding the pain, it's gonna be what? Radiating to the back. Always they are gonna mention on the scenario that he's having a sharp sudden pain which radiate to the back. Serious complication possible, particularly will be the pancreas become what? Infected after having the acute pancreatitis and the inflammation. Many bacteria can go there and be contaminated. Regarding the chronic pancreatitis, it's marked by the persistent inflammation for a long time, as we said, caused what? Damage to the vital organs. So there is an impairment of the endocrine and the exocrine function. Chronic pancreatitis considered as a life-threatening, and complications including the liver failure, diabetes, and pancreatic cancer. This picture, this slide, we could say it's a summary for everything we should know regarding the acute and the chronic pancreatitis. So again, for the acute pancreatitis, we said there is an auto-digestion of the pancreas by the pancreatic enzymes itself. Why? Because it should be in active form in the pancreas. If it's converted to the active form, it's going to start auto-digestion. It's going to eat those enzymes, literally, it's going to eat the pancreas tissue. The causes, there is a mnemonic called I get smashed, which means it could be idiopathic, gallstones, ethanol, which mean alcohol, trauma, steroids, mumps infection, autoimmune, scorpion, hypercalcemia, and hypercholesterolemia, ARCB, which is a diagnostic and a therapeutic way to treat if we are having any stones. It could lead also to inflammation of the pancreas and some drugs, no need to go this depth. And mainly we should know the gallstones and alcohol. Always they are going to ask us about gallstones and ethanol and alcohol. طيب, the diagnostic, we should meet 2 out of those 3 criteria. One of them is going to be the acute epigastric pain, often radiating to the back, as I already mentioned. Also the serum amylase and lipase, and the lipase is more specific than the amylase. Why? Because amylase is even secreted by the salivary, the salivary glands. While lipase only for what? Only for the pancreas. All of them are going to be X3 at least, upper than the limited normal range. This is also a characteristic for it. The third part of the criteria, we should have an image finding, as we can see on this picture. What are the imaging findings? It include what swelling of the pancreas itself. That's all regarding the acute pancreatitis. Regarding the chronic pancreatitis, there is a chronic inflammation and atrophy and calcification of the pancreas. In the acute one, we are not having the atrophy and calcification, but with a persistent inflammation, we are going to start having the atrophy, shrinking of the pancreas, as well as calcium deposition. So it's going to lead to what? Calcification of the pancreas, and we can see it here on this picture. See, there is a calcification. All those whitish on the pancreas itself, these are the calcification. While if we are comparing it to the acute pancreatitis, we cannot see any white spot here. So that indicate a chronic pancreatitis. The major risk factors for the chronic pancreatitis including alcohol as well as genetic predisposition. So alcohol is a part for both. If we are talking about the acute pancreatitis, because alcohol can lead to pancreatitis by many ways. Even I think there was a question about that in the last progress test, and the answer was by the direct toxic effect on the pancreas. That's going to be a part of the acute pancreatitis. While with the persistent, it's going to be by many other ways. So for the chronic pancreatitis, we should remember that alcohol and genetic predisposition, as well as there is an atrophy, shrinking of the pancreas, as well as calcification due to the persistent inflammation. Amylase and lipase may or not be elevated. While in the acute pancreatitis, we said it's a part of the criteria and it's going to be X3 at least for amylase and lipase more than the normal. While for the chronic, it's not going to be elevated. Why? Because already the pancreas is what is consumed. And as we already mentioned in the previous slide, there is an impairment in the endocrine and exocrine function. So we are not secreting the enzymes probably. So we cannot detect any elevation of amylase and lipase because already the pancreas is overconsumed and it cannot secrete any hormones. Thanks. Any questions regarding this case or any part of what I explained?
كل الهدف من الابلكيشن اللي هتحصل فيها تعمل ريسبتور سترونج افينيتي وسترونج سبيسيفيستي الانتيجين اللي كونها في الاول